So let's talk about some of the problems with diabetes. I already mentioned to you that in diabetes, if it's not being treated appropriately, you end up with very high blood sugar levels because the insulin isn't present to open up the cells to pull the sugar out of the blood. So when you have too high, so remember hyper is high, so high blood sugar. So there you go. High, hyperglyc, remember, is sugar, and emia is in the blood. So high sugar in the blood. There are actually two problems that can result. The first is called diabetic ketoacidosis. And the second is a fancy word, hyperosmolar hyperglycemic non-ketotic coma. And actually there's a more generic term that's called HHS, which is hyperosmolar hyperglycemic state. And that just refers to the fact that you can have these patients with very high blood sugar levels who are in this kind of hyperosmolar hyperglycemic state that have not yet gotten to coma, right? So these are both high blood sugar conditions, and hypoglycemia is low blood sugar. And you can see both of these with diabetics. So hyperglycemia causes, well, it could be a new onset diabetic, so maybe they don't know they're diabetic. It could be that the patient's not taking their insulin. It could be that they've taken in too much sugar, so they're overeating or they're eating the wrong diet. And then any kind of stress on the body. It could be fever or infection or emotional stress. Patients who go onto steroids actually have issues with high blood sugar. I had a patient once who was having a heart attack, and she was an elderly patient with dementia, so she couldn't complain of anything. And the reason that we got called out was actually for a very high blood sugar in this patient who was not a known diabetic. So, stresses, any type of stress on the body will cause high blood sugar. Now, when the blood sugar gets high enough, you can enter one of the two conditions that I mentioned earlier. You could have diabetic ketoacidosis, and these are usually in type 1 diabetics. And what happens in this process is that your patient has no insulin, the blood sugar goes up, the kidneys try to remove excess sugar by increasing your urine production. So you start peeing out sugar. So pee out sugar. But you know what? That doesn't fix the problem because you still don't have any insulin. So your blood sugar stays high and your kidneys keep peeing out. You keep making more and more pee. So these patients have what's called polyuria. They're just peeing a whole lot. Ultimately, what ends up happening is they start peeing out so much they become volume depleted. So they run low on their blood volume because they're peeing it all out. So they end up thirsty, which is called polydipsia. They have tachycardia and hypotension, possibly. And then dry skin and mucous membranes. And these symptoms, this is a basically beginning of a hypovolemic shock. And that's why you see these symptoms here, because they are peeing out so much liquid. Now here's the other problem. The cells, the muscle cells and liver cells and kidney cells, they don't have any sugar. They can't burn sugar. So the patient feels hungry. So they're going to be hungry all the time. The cells actually start burning fat as an alternative fuel. And when you burn fat, you produce these ketone bodies. All right, and these ketone bodies, you may think this sounds kind of like acetone. And it actually is. Acetone is a type of a ketone. These patients actually are producing these things that are kind of like acetone. They're called ketone bodies. The patient's going to try to correct this acidosis, so that's an acidic ketone, so they're going to be acidotic. So they're going to start breathing more. They're going to breathe more and faster, and they're going to have this rapid, deep breathing to help get rid of this carbon dioxide. This rapid, deep breathing is called Kussmaul's respirations. And then the exhaled ketone bodies produce kind of an odor like acetone, like nail polish remover, or almost kind of a fruity breath odor. So these patients, you know, if you suspect that might be something that's going on, do kind of try and get a little whiff of their breath and see if they have kind of a fruity odor on their breath. It's pretty noticeable, So the keys here in diabetic ketoacidosis, I'm going to add one. Type 1 diabetics, so no insulin at all. They are volume depleted, and they have ketone body production because their bodies are burning fats instead of sugars. Now I'm going to talk about HHNC. I already said this once, so I'm not going to say it again because it's a lot to say. These are usually in type 2 diabetics, which means they have inadequate insulin. But they still have some, and that's actually the key here, is that they still have some. They still have some insulin. So what happens? Well, the blood sugar rises, just like in DKA. The kidneys try to remove the excess sugar, so they increase urine production. Patient becomes volume depleted. They're thirsty. They have tachycardia, hypotension, dry skin, and mucous membranes. So all of this is the same as DKA, right? But what's different? So here's the thing. Because there's some insulin, the cells are continuing to burn sugar because there's some sugar that can get through. So the cells are getting a little bit of sugar, they're just not getting enough. Because they're burning sugar and they're not burning fats, you don't get this fruity breath odor. You don't get the ketones because no fats are being burned. With HHNC, this one tends to be a fairly severe condition. You can have blood sugars, so normal blood sugar is about 70 to 110. And it's milligrams of glucose per deciliter. Brush up on your metric system there, per deciliter of blood. So that's normal. In these patients with HHNC, theirs can be sometimes, over 500-600, all the way up to 1,000. Just incredibly high blood sugars. And their body keeps, it's kind of a spiral, their cells are saying, I'm not getting enough sugar, I'm not getting enough sugar, so the body just continues to raise the blood sugar until it reaches these, 1,000 milligrams per deciliter, which is really high. So the keys with HHNC, type 2, diabetics usually, they have severe volume depletion and no ketone body production. So what's the general management for hyperglycemia? Well, we're going to support the ABCs, treat them for hypovolemic shock, transport. And this says when in doubt, give sugar. And I'll talk about this. I don't always like this. I don't like the when in doubt, give sugar, mostly because we have glucometers. We can actually measure very easily. Oops, glucometer. We can measure very easily what their blood sugar is. If it's high, they don't need sugar. They actually need insulin to help their cells get the sugar that's already in their blood. But we don't give insulin at all, ever. In the pre-hospital setting. It's not something we do currently. So if your patient ever asks you to help them with insulin, or if you ever think maybe I could just give them some insulin, they'd feel better, don't do it because it's not something we do. So use the glucometer, check a sugar. If you happen to be working in a system where you don't have a glucometer and the patient's complaining of signs and symptoms of hypoglycemia, then you can consider giving sugar. But yeah, hyperglycemia, if we know they're hyperglycemic, we want to avoid giving them sugar.